like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's life? The current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. I believe it's unethical. This is criminal. 95% of the country is still functioning in the fee-for-service model. I definitely believe everyone should be treated the same.
Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Thank you for joining me this week again for another episode of Fridays with Faisel. I believe that everyone deserves access to quality primary care and should be treated the same, regardless of their ability to pay. This week's topic is the cost of misinformation. But what if the cost is not a dollar amount? What if the cost of being misinformed impacts your health? And what if we're talking about the health of the entire country? Oftentimes, I reflect on sayings from my father from my childhood. And I remember asking him when I was young about the cost of things. And he would tell me, be careful, make sure you research and you know before you spend even $1, because in America, you pay for what you don't know. So I'm excited this week about our topic, the cost of misinformation. We got Robert. Robert, how you doing, Robert?
I'm good. How are you?
I just, we're supposed to be moving today. My wife is not pleased. About 9 hours ago, 3 o'clock in the morning, she said we had to pull the plug because the house wasn't cleaned properly. There was issues with the movers and it's just been, so the move is going to be delayed by a couple of weeks. So overall, I'm glad to be here with you, but I wish I'd be doing it from the new house.
Yeah. I'm glad to be here too, Faisel. And as I'm looking at myself on the screen, I'm also realizing my shirt matches the background. So that was perhaps not the best choice, but I'm excited about our topic today as well. I think there's a lot of different things we can do with this. And I think sort of the idea for this topic came up with respect to COVID-19. And I think all of us, both in the healthcare community and outside of it, have seen a lot of messaging come across that's either intentionally misinformation or just interpreted as misinformation because it's a part of sort of the scientific process. But misinformation isn't new to healthcare. There's been a lot of misinformation on nutrition, a lot of misinformation on sort of a large scale healthcare transformation plans, sometimes for political gain, sometimes just for profit gain. So misinformation is always with us in healthcare, and it has costs that exceed just the dollar amount. It has costs of human life. It has costs for people's quality of life. And so I think it's a really important topic for us to chat about. I think we should kick things off with talking about COVID-19 misinformation. But first, let's introduce our guests. Yes. So we have Dave Chase. So please introduce yourself, Dave.
Hi, I'm Dave Chase. I co-founded an organization called Health Rosetta and just authored a book that we'll have a free download for called Relocalizing Health. And so I'm not a clinician. The perspective I'll bring is kind of from both a business perspective, but I also volunteer as a high school track and cross country coach. And as I was thinking about this topics and seeing some of the impact on kids, I think there's actually some relevance there in terms of outdated information. Maybe it wasn't intentional misinformation, but how long a shelf life that has. And so, our organization feels that there's more than enough money to not only fund a world-class healthcare system, but fund what's been defunded, that actually drives 80% of health outcomes. The sick care system only drives 10 or 20% of health outcomes. So we're very focused in on how do we get rid of that waste, turn it into value. And I'm sure we'll talk more about it. But and one way I look at COVID is it's really a super spreader of a set of pre-existing conditions that we've had. And I think we'll probably talk about it.
And Dave, I see you have the factors that poster in your back over
Yes.
there. It's all the factors that impact health, from socioeconomic to lifestyle behaviors to the medical care system itself. So big fan of that particular graphic. So
Yeah.
funny to see that there.
Good eye.
And yeah, I actually just posted about it on LinkedIn, so I see it. It's fresh in my mind. And we also have Dr. Lewis joining us today as well.
Hey,
Stephen,
how's it
welcome.
going? Thank you. So just to introduce myself, I'm the regional medical director for ChinMed Senior Medical Centers, focusing mainly in the Virginia, Tennessee, also New Orleans. Kind of that's kind of the general area that I practice in. But really excited about this conversation. We have, this is the first pandemic where social media has kind of been the largest source, or one of the largest sources for information. That's where a lot of people get their information, and fortunately, it's a very powerful tool. Unfortunately, any individual can be kind of their own, have their own soapbox and their own source of information for their entire network. So, I wish we could kind of sometimes socially distance our social media, where we can, make sure we're getting the right information to everyone. But really excited about this conversation, excited about where our abilities to spread information are going to be going in our future, hopefully, future healthcare crises and pandemics. Hopefully we don't have any more pandemics like this. But very excited to be here. Thank you for having me.
Yeah, excellent. Thanks for joining us.
And Dr. Dan. Let's get Dr. Hey, Dr. Dan. Good to see you.
Hey, Faisal, how are you?
Well, you can imagine with everything going.
Right.
Thank you so much, Dr. Dan.
Yeah, it's great to be here with you. Love hearing what you all have to say about this important topic. And if there are any questions that come up, I just ask anybody who's listening in to please chat them, and we'll do our best to get to those as well.
Wonderful. All righty. Well, let's get the conversation started.
Yeah.
Welcome to the guest, anyone who's joining in live on LinkedIn, Twitter, and Facebook.
Yep. So Faisal, I think Dr. Lewis brought up a really good point, and I think this is a good starting place for us to kick off the conversation here. Back a long time ago, when there were previous pandemics or just anything going on, there was sort of a bit of a filtering process that went through sort of public information that went out. But now with social media, there's this ability for everybody to be an expert, or everybody to communicate their opinions, whether based in science or not. And so that's really fueled a lot of the misinformation that's come out about COVID-19. So I guess I'd like to pose a question to everybody, which is, what do you think has been the most impactful piece of misinformation that's been said to the general public that may have had a negative or even positive influence on what we're seeing today with regard to COVID-19? So why don't you take this one off, Dave?
It's a good question. I think probably one of the biggest areas of confusion that's ended up having a long shelf life was because of the shortage of sort of clinical grade masks. Mm-hmm. There was this early guidance, and again, we didn't have that much knowledge early on about masks. So there was a real concern that people were going to keep the frontline healthcare workers from having adequate masking. And so it was like, mm-hmm. Don't wear masks, don't do that. And that was early on, probably when the public was paying the most attention. There's a whole dynamic of politicization there, but I think most people, there's certainly people in their extreme political camps, but I think the everyday person just kind of wants to get good information. And so that was probably the single biggest one, is confusion around masking and how there's no one silver bullet or panacea in this thing, but that's certainly an important part of the picture that I think to this day, it's actually, you look at some of the progress, it's better than what a lot of people are seeing in the media in terms of people wearing masks and all that as one piece of the puzzle. But I'd say that's probably the one that comes to mind for me.
Yeah. So the early guidance from sort of high levels to try and preserve the supply of masks for frontline healthcare professionals led people to think that they aren't effective at an early stage. And then, when that guidance was reversed after manufacturing was able to pick back up again, then people were like, you told us not to wear masks, so why are you telling us differently now? And part of that, I think, is obviously for protecting, having those priorities for this frontline personnel. But we've also had a lot of changes come out as we've researched this disease, learned a little bit more information, and then guidance has also shifted in other areas. And I think that in clinical practice, for example, there may be some examples of how guidance has shifted over time with dealing with COVID-19. So I think Faisal and Dr. Lewis, why don't we chat about sort of some of the clinical aspects that have come out that may have been different at the beginning of the pandemic, and now that we've learned more, how has that changed?
I think if Stephen, if I could just get started a little before we get really into it with the COVID, is take a step back even before COVID. So even taking a step back prior to COVID, half of all medical care in the country was delivered in the emergency room setting. So far as early interventions are concerned, we were not doing a good job as a country with addressing chronic medical management, nipping things in the bud. So that's one component. And then the second component is with prevention in general. I mean, if we look at influenza, as a country, less than half of American adults get vaccinated at the end of the flu season against the flu. So far as prevention and early intervention are concerned, I think a lot of that is driven by our fee-for-service system. Our fee-for-service system is a system that does very, very well at generating revenue by billing. It does an excellent job of that. But there's no incentive. There's absolutely no incentive in our current system to prevent or to nip things in the bud. So even prior to that. So how would we address the anti-vaxxers? There are people who don't, the group of people who are against vaccines. How do we engage with that population of people? I mean, I look at my 3-year-old. I took him for his well visit, and very commonly you'll see in pediatricians' offices that if you will not agree to get vaccinations, then the pediatrician will not see your child. And that's not the way that we should be engaging people as doctors in the medical community. And once we know that there's this distrust, there's this fear, that we don't have a culture of incentivizing prevention and early intervention. So we must be creative with how we engage with those parts of the population. And misinformation has been there on social media. The latest thing I've read about, have you all heard about bee venom? Have you heard of that? That people are using bee venom for like Lyme disease, like chronic pain from Lyme disease and multiple sclerosis and all this sort of stuff. It's all over. My wife showed it to me, and just over the weekend. And I thought, my gosh, we have struggled as a society with misinformation towards health for God knows how long, and it's just amplified now because many people aren't aware of or familiar with the scientific process, the scientific method. I'm sorry. We learn. You learn. We don't just say that, okay, well, this is the truth and that's it. I mean, we adapt, we respond. And like you said, Dave, with the original guidance about, hey, let's preserve the masks for Healthline, for people, especially for people who are directly involved with patient care, the general public, I mean, most of the general public doesn't think that couldn't imagine that our hospitals and our healthcare systems can't protect nurses and doctors. That was a big shock, I'm sure, to many people. But then again, to many people, remember, we're already paying as a country. Another point that you said, Dave, about that we're already paying too much. You're right. We're already paying $10,000 every time somebody gets treated for pneumonia. The cost is about $10,000 for $10 pneumonia. That's the same treatment in the outpatient setting, $10 in the outpatient setting.
Just to add on, I think, I definitely agree with all of your comments, particularly early on during the COVID epidemic. What ended up happening was we didn't have enough information about how it spread. We didn't have information of exactly how to protect yourself very early on in terms of, the world spread of COVID. By the time it really started to spread in the US, we had a lot of that information. Unfortunately, what really happened, and even going back to the point of what was the most dangerous information, I definitely agree with Dave about the mask information being very dangerous early on. But the second thing was basically all the conspiracy around this being created intentionally, and this being even more of a cultural phenomenon, being an Asian issue, or, all of that. Once the population has, this herd mentality, once the population has a negative experience with any type of, government or the healthcare community, it automatically is immediately resistant, or, very conscious about any recommendations that are put out. And so once you have that initial thought where it's spreading that this was created by the government for some reason, then it's hard for people to trust what's coming out of the government. It's hard for people to trust what's coming out of the healthcare community and following those recommendations. And whenever, I always say that healthcare is the opposite of being a meteorologist. The healthcare community is not forgiving for you being incorrect at all. We are not allowed to be incorrect. But somehow I feel like it's going to rain when it's like no chance of raining outside on a regular basis. And so we don't have that ability. And mainly that's because we're in charge of people's lives. I mean, we are saving and caring for people. And when you make errors, or when you have years of flu vaccinations that did cause harm to people, even though they saved a lot more people than they caused harm, those stories, those anecdotes, those small numbers of people that had a negative reaction, really, it has decades of an effect. I mean, we're practicing with seniors at ChinMed, and I have patients that won't get the flu shot because they got a runny nose 30 years ago. That's kind of what we're dealing with. And so we really, as a healthcare community, really have to focus on the data, focus on the outcomes that we know of, and spread that information, because we're fighting against a horde of information that's really just not helpful in terms of protecting and preventing those illnesses, like you were talking about, Faisal.
Yeah, and one of the things that I have learned quite a bit about during this period of time has been the power of the anecdote and the story to spread information, rather than the ability to communicate like scientific based information. And the thing is that, a lot of the conclusions we want to make about whether something works or not should be drawn empirically from science and the scientific method, whereas the story resonates more with people. So a single story of a bad outcome from a vaccine at one point in time, or a single anecdote about COVID-19 can shape somebody's entire knowledge of the disease, rather than the way we want to generate knowledge, which is through an empirical process. And it's much more difficult to explain an empirical process and how we got to these conclusions than it is for somebody to say, oh, this worked for me. And the general public typically might believe that. I think we saw that during sort of the early days of hydroxychloroquine, when that was sort of touted as a potential treatment because of some anecdotal evidence. And then, more recently, we've seen those randomized clinical trials come out, which is an empirical method that says it probably doesn't work very well in COVID-19. So those are the types of things that I think have been sort of an interesting dichotomy between the anecdotes and stories to educate versus the ability to communicate scientific fact. And Dr. Dan, I think you're here for a question.
Yeah, well, a comment and a question. One of the people watching today asked about, was just making the comment that misinformation or a herd immunity is the bane of my existence. And then Michael asked, and it's sort of the same type deal. Michael asked, are any of you participating in the vaccination trials? So, and I don't know the answer if any of you are participating in them. So we put it out there and let you all have at that.
Great comments, great questions. It hasn't gotten to us. We're not, at least I know for ChenMed, we're not participating in any of the vaccination trials. None of our patients.
Near me in DC, George Washington University is conducting one of the Moderna trials, and I get all the targeted ads. So I've been considering going down there and participating, actually. But given a proper scientific review of the evidence and my own review of the published papers that come out, I will be getting the vaccine once it's available, and it's available to me. So that's something I think will be really important. And then herd immunity. I think this is a good topic to hop off unless somebody else wants to comment on their participation in a vaccination trial. Anybody else doing it, touching the vaccines? Just
I have not taken part. I haven't been contacted. I wouldn't be opposed. But I'm not currently taking part in any of the trials.
Excellent. So herd immunity is a big topic that's come out that's sort of been a high-level strategy that's been touted by governments and various organizations that want to just kind of let the virus rip. So herd immunity is typically talked about in the sense of vaccination, trying to get to 85% of a population vaccinated and immune to protect the 15% that may not get that vaccine. And so it's usually talked about in that sense. But here, a lot of people and a lot of government entities or individuals have touted herd immunity as an approach to the virus, where we don't worry about it, we let it spread, and then by doing so, we will have people develop the immunity to the virus, and then we'll have herd immunity. But in that process, you infect a large number of people, and therefore a large number of people will get sick, and therefore a large number of people will die. So that's been a really big, topic. So I'd love to hear your thoughts on that, Dave, the sort of misinformation around herd immunity.
Yeah, and I think that one of the real guidances going into pandemic, there's been pandemic plans for some time, and seeing which countries, which locales, which provinces follow those or not. And one of the fundamental things is when there is something like a pandemic, it's obviously scary for people, that the guidance is politicians go to the background, public health people go to the foreground. And I'll take it out of the US since we're in a pretty politically heated environment, because I'm in the Pacific Northwest, live very close to British Columbia, and my daughter goes to school in Toronto, Ontario. And BC is much more like Korea or New Zealand or something like that in terms of how they've handled COVID. Ontario, they've not done as well. Well, what's the difference? In Ontario, their premier has been the vocal face up front, sometimes giving good information, sometimes not. In BC, first of all, the pre-existing condition was they valued public health, and they had a proper public health department. But then Dr. Bonnie Henry, she came to the fore, and she has been this constant flow of information that is based on the latest science, including on things like herd immunity. And you see as a consequence that even though BC in many ways within North America should have been one of the most exposed places, because they not only are close to Seattle, where the first US cases were, but they have a very large Chinese population, lots of flights coming in from China and throughout Asia. And despite that, they've done remarkably well. And so really, we have that, then the credible information I've read really debunks the notion of, if you believe in the sanctity of life, you don't believe in herd immunity without the vaccine approach to it. And so they have done that. Nobody's waiting around. They're doing the right things. And they've struck a balance. There were times where people were going to bars a little bit too much in the summer, and there was some stuff. And she kind of held her fire, because she knew there's going to be a time in the fall we're going to have to really be more careful about it, because people are going to be indoors much more. And so they've struck that right balance from what I've seen.
Right. And I think that the core thing that you said was having a public health leader sort of be at the forefront and be able to interpret the science as it comes in, and to communicate that to the general public in a way that is empathetic, to say, hey, look, this is a difficult situation. We're all a part of it. And it's extremely frustrating. It's causing a lot of mental strife, a lot of depression. It's caused a lot of harm for people from an employment perspective and financially. And it's a very scary time. And so it's not a time to go up there and sort of just talk about science. It's a time to be empathetic and communicating why we think this is the best way to do it and how it's going to protect, the general public. So I think that those were excellent points there, Dave.
Robert,
go ahead.
Robert, just to chime in on that, you mentioned the finances. I think for impact, the BBC and Harvard actually looked at the amount of hospital admissions that they think came from misinformation. And essentially, they think around 800 people died and around close to 6,000 people have been admitted to the hospital. So just in terms of the magnitude and the dollars amounts, you're looking at for like a non-complicated COVID admission to the hospital, you're somewhere around $13,000 in terms of the cost of the admission. If you end up on a ventilator for even just a couple of days, you're looking at somewhere in the $30,000 to $40,000 range. And if you're in on the ventilator for 4 days or more, you're looking at up to $80,000. So you're looking, on the higher end, if you're assuming a lot of those admissions were really complicated, you're looking at potentially $4 to $5 billion worth of money spent on just the misinformation. This is not the total number spent on COVID. And even if you had all of those admissions were just COVID without any major complications, you're still looking at like close to $100 million being spent just from misinformation. And all of this research is relatively new, but it's an incredible impact when the average copay for a person is, $1,400, somewhere around there for a hospital admission. And most of my patients don't have $1,400 extra dollars. So it's an extreme impact on population.
Right.
Yeah, and being reactive. Oh, sorry.
No, that's okay. So Scott asked a good question here. I think a big aspect of misinformation is we hear trust to science, but there seems to always be doctors on both sides of whatever issue is being discussed, especially COVID. What's your advice on who to listen to? And just in the background, I just Googled quickly, and it turns out that there are about 2 million scientific articles published every year in the world. So that is what even the best scientists in the world are trying to keep up with. So would love to hear what your thoughts are about that.
Dr. Dan, before you leave, it reminds me of that joke. I think you're the one who told me that if you get 100 doctors in the room and we're talking about any one particular subject, that you'd end up having probably 150 different opinions or something along those lines. I can't remember that. And sadly, what do you do when that's being played out on social media, where everyone can just put out whatever they want? And there are topics like this, herd immunity, having a reactive sort of approach. Can we afford to have a reactive approach to this condition, which is really, I don't know if we've ever had this is acting more and more, COVID is acting more and more like a vasculitis or a vasculopathy, all different sorts of presentations. About 80% of the people have mild to no symptoms. When I try to compare that to anything in medicine in general, I think about hypertension, really just cardiovascular disease in general. As like, if you had to pick like a condition that half of Americans struggle with, it's cardiovascular disease, and that's driven by hypertension. And I think a reason why that's driven by hypertension is that 95% of hypertension doesn't have any symptoms. Only 5% of people with hypertension have symptoms. And now we're dealing with this disease that 80% of the people have mild to no symptoms. 15% have like moderate symptoms, about 5% end up having severe symptoms. So even prior to COVID, we have struggled as a society with just approaching something as basic as hypertension. Where we now, I don't know, Dave, in the Northwest, what grocery store chain you have, but that offers blood pressure medicines and antibiotics for free. Here in this part of the country, in Florida, we have the Publix grocery store chain. So blood pressure medicine like lisinopril and amlodipine is free. All you need is a prescription. 5 antibiotics is free. All you need is a prescription. Same thing with metformin. Metformin's now free at Publix. Singular is free for asthma and COPD. And then there's Walmart. Walmart has over 80 medications for $4 a month. But the thing is that if we don't have a system that values prevention and nipping things in the bud, we have a culture that just kind of pushes forward. The American culture kind of pushes forward. You have a little bit of a runny nose. I'll go into work. I can push through this thing. Now, my concern is that, okay, we have now horribly over 228,000 Americans have died from COVID. We have over 7 million Americans who've been diagnosed with COVID. God knows what the long-term impacts are with this diagnosis, having this as a past medical condition. Have you been, any of you read about the long COVID? If you go on Twitter and you look at a lot of, I mean, and because it impacts people in different ways, you know, some people, they have GI complaints, nausea, diarrhea, vomiting, you know, then of course those are the ones that we're reading on, you know, online with all the lung impact with the shortness of breath and people going on the ventilators. But COVID presents itself in many different ways.
Yeah. And so Scott, let's just take a second to look at his question here. Scott, this is one of my biggest, I don't like this at all. And what I typically do myself when I see these types of things is I say, okay, where are they getting their information from? Because if it's just a physician who's treated a couple of COVID patients and tried something and then they think it works and then they're talking about it, that's not, you know, empirical. So what I always do is say, okay, where is this person getting the information? Where do they say they got it from? And then I try to trace it back to the peer-reviewed journal article that they're referencing, if they are even referencing a peer-reviewed journal article. If it's not referenced, then I don't believe anything that anybody says. So they need to be able to reference where the methods that we found this information came from. So, for example, when all the sort of anecdotes came out about hydroxychloroquine back in April, the first thing I did was I went to the New England Journal of Medicine, I went to JAMA, and I said, let's take a look at here. Now, sometimes studies have poor methods, they have bad sample sizes, they're not necessarily going to be the end-all be-all answer. And science is a process. It takes 10, 15 years to get consensus on a couple of different items with larger studies with better methods. So my advice to people when they say they're hearing something, even from somebody with an MD or even from somebody with a PhD, is, okay, let's go look and see where this was published first. Let's look at that information. Let's make sure that the study was sound. You know, did they have enough people in the study? Was the group of people diverse enough in that study to draw conclusions about sort of the general public? Were their methods reasonable? Was it funded by something that has sort of a financial interest in making this information public? And so those are the types of questions that I ask when I see even somebody in a white coat talking about something. We saw that big presentation of doctors in front of the Supreme Court talking about hydroxychloroquine. I'm here to tell you that I've read a lot of the studies in New England Journal and it doesn't work. So they were all up there talking, and it was exceptionally disappointing to me to see that. But they didn't reference any articles. They may have referenced one study that was flawed out of France, but it wasn't published in sort of a premier top level academic medical journal. So that's my advice in this situation. Unfortunately, we do have people who still rely on anecdotal evidence, and evidence-based medicine is still, rather new. So it's something that is still trying to be promoted. And so I always look at those elements. And if you look up, for people who are watching this also interested in this, if you look up, ways to rate clinical evidence, there's a lot of really good steps of things to look for in journal articles that have been published. So that's something else to keep in mind when you're looking for the true source of information. So I think that's sort of the way I usually answer that question. Does anybody else have anything to add?
I would say the doctor-patient relationship, the importance of the doctor-patient relationship. Who would know you best, Scott? Your primary care doctor should know you best, especially during this time of uncertainty. There's only one person that we should be turning to. All of us should have a good relationship with a primary care doctor, because this is what ends up happening. We all end up having to try to find different ways, who to go to, who to read, what's driving people to come to these conclusions. I oftentimes think about in the early days of COVID, right before all the restrictions, travel restrictions and all. I was in Baton Rouge, Louisiana, and my father, Robert, I don't know if I told you, my father called me. Because remember those days, there was just every day. This is back in February. Every day there was a different thing coming out in the news. Mm-hmm. And my father's almost 70 years old. And he called me while I was at the airport. And he said, there's a lot of stuff on the news, but I spoke with my doctor. And my doctor told me that, as long as I wear a mask, as long as when I go out in public, I only go out if I really need to go out, try to avoid being in large crowds, should be okay, and wash my hands frequently. And I said, okay, Dad, good advice. Your doctor said that? And he said, yeah, my doctor said that. I trust my doctor.
Gotcha. Yeah. So let me bring this back to sort of the cost of misinformation here. So we've talked about a lot of the misinformation. But let's talk about sort of what the outcomes from this might be and what we're seeing in the US right now. So Dr. Lewis, what are you seeing in terms of, either in your practice or nationally, what's going on with some of these misinformation, and, how is it affecting the general public? How is it affecting your patients?
Well, I think the biggest issue that we have is a lot of people are becoming more and more siloed in terms of where they're getting their information. And so what's happening, the concern as things proceed is if people are already feeling and they know that they're getting misinformation, they're going to go to their most trusted source, which is often not a great source for information. And so it's going to be these siloed private groups or social networks of people that are getting this small amount of information. And in terms of how it's affecting in a clinical practice, lots of patients coming in wearing on both extremes. Some say, hey, I saw the president get better, and I saw my cousin get better, and I don't think it's that big of a deal, so I'm not going to wear a mask at all. And I'm not really concerned about it at this point. It's been around, and I'll get it or I won't get it. That's kind of one extreme. The other extreme is seeing people wear a mask all the time when they're alone in their car, when they're walking outside, when they're in their house. That kind of other extreme, people are feeling like they absolutely have to have that mask on to protect themselves when they may not see people for days or weeks, but they are that concerned. And so the long-term impact is going to be just a buildup and lack of trust of the information that's going to be coming out, because hopefully COVID just disappears in 8 months. That would be nice, or 2 months for that matter. But it's very likely that we're going to be dealing with COVID for a long period going forward. And if we're breeding this distrust of the science that we're getting, then we're going to have a big issue. The other thing is, not to poke, holes in any particular administration, but there's been a lot of back and forth within the science that's being provided outside of the administration and the CDC. And so if that's not a clear message by people that know what they're talking about, then this is going to continue to build mistrust for the next year. So.
Right. And beyond, even. I think you're spot on there. So, Dave, what are we looking at based on your experience and what you're seeing and who you're talking to? What are we looking at for the next, let's say 6 months? What do you foresee coming out, and what does that mean for everyday people's lives and for the health system in general?
Yeah, there's a lot going on. There's a lot of confusion, and we particularly work a lot with, we call mid-market employers, sort of the 50 to 5,000 employee. There's about 90 million Americans in that bucket. Overall, about half of Americans get their health care through their employer. So that's my particular lens. And there's no guidance, really to them. There's some of the jumbo employers have more resources and, have consulting firms, giving them return to work programs and that type of thing. These organizations have very little, and they're very worried about it. And we've seen claims for basic tests from $5 to $100 to $10,000, over $10,000 at some hospitals. And this scares the, what out of some of these employers. And they think that the carriers actually have their interests in mind, and that's a whole other topic. But it's a bizarre environment where, at a time when, like, one of my big worries is we know there's no well-functioning healthcare system in the world not built on proper primary care. The most vulnerable primary care right now are these independent medical practices that were and are hooked on the fee-for-service revenue stream, and they're closing up when they should be the front lines of this. At the same time, in a global pandemic, the carriers have continued to collect premiums, at least for the ones that are fully insured, in this environment, and have had record earnings. Not only last decade have they had Amazon-like returns in their stock price, but they've had absolute record earnings. That's how upside down our system is. the people who should be in the front lines are primary care, and are suffering, really suffering. They're doing their best to keep their doors open, and some are, they have patients who've lost their insurance, and they still care for them and really doing wonderful work. But they worry about themselves and their employees and all that. And so my hope is that, I mentioned earlier that COVID kind of being a super spreader of pre-existing conditions. And, one of the things that is one of the more shocking things I will say to people, but it's absolutely true, is healthcare isn't expensive. After all, clinicians are only getting 27 cents of every dollar we ostensibly spend on healthcare. Doctors only 8 cents of that. What's expensive is price gouging, profiteering, administrative bloat, outright fraud. And so we are seeing more awareness on this issue, that because this is a crisis that actually is in the health arena, some employers who just kind of like, just tell HR, just keep our people happy, don't get us sued. They're now realizing, oh my gosh, half of the American workforce is functionally uninsured. When your deductible is more than your life savings, like, you're worried about that test to even go in, right? And that's one of the things I really worry about, is people who actually should go get the test, like, my gosh, I've got a $6,000 deductible. I might get charged $10,000. I'm going to take my chances because I don't want to, put our family in harm's way. So those type of things, it's like this real confluence of that. On the other hand, and I mean, obviously with the doctors on this session, they know, like, our primary care system at its best is just doing amazing work right now, because when they're not on fee for service, they're hitting their stride. They had to do course corrections to, maybe have less face-to-face impact. We see that in the employer space. So people are seeing this like, oh my gosh, sometimes people ask me like, how do you look at this? And why did you start this thing? And I was like, well, on the one hand, you have this dystopian reality, even pre-COVID, of, terrible outcomes, bankrupting countries, burning out doctors. And on the other hand, you have the ChenMeds and the Ioras and the, Oak Streets and so on out there. It's utopia by comparison. It couldn't be more different. And I was like, hey, it's just a marketing challenge, right? Everybody would want that if they knew about it. And so, I just have tried to turbocharge. I mean, I say my real job title is Johnny Appleseed. I don't have to invent the stuff. I just spread it around. And the good stuff is ready to be spread around. And that's what we're really trying to do.
Right. And so we have the spread of this disease that spreads better in colder air. So we're expecting to see more people with COVID infections. With more infections comes more people with those pre-existing conditions, those comorbidities that put them at higher risk for bad outcomes. And we have a primary care system that's being really stifled by the fee-for-service system that is causing them to close their doors. So people are not getting care for both COVID unless things end up in the hospital, and they're also not getting that routine care as they should be for their chronic illnesses. So we're looking at sort of a health crisis moving down the road as this disease continues to get out of control because of the lack of measures here. So it's a relatively bleak outlook for healthcare, but it's also at the same time positively exposed some of these big gaps in the system. And organizations like ChenMed and like Health Rosetta are trying to improve the way that we manage primary care. And I should also add Avenue into that mix too. We're trying to do that same thing.
Well, so we know. Yeah, I'm sorry. I think in a lot of ways we're in a World War II like event. And if you look at what happened during and after World War II, some of, whether it's National Health Service, our employer-based system, the changes are dramatic. That doesn't mean they'll be good, but they can be good. And that's where I believe that good can come out of this. And it's, the cliche, it's darkest before the dawn. And I do think we're in the situation that this is, we've had this Cadillac priced healthcare system that's been producing Pinto Health Outcomes, and that Pinto just got rear-ended by COVID, and it's blowing up the system. And it was a pre-existing virus, metaphorical virus in the system. And now is the time. It's been, this giant spotlight on how failed this fee-for-service volume-centric model has been.
Right. So I think that's really
this
important.
this will help drive the incentive to be towards health. The incentive ought to be to improve health, and even outside of outside of the pathophysiology of this failed system. As I'm reading more and more on a weekly, daily, sometimes basis about how many Americans are filing for bankruptcy because of medical billing or surprise billing. I just read just this last week about UVA and what they're doing with going after, like 1 in 5 Americans is in some stage of debt collection because of medical billing. And they're not in debt collection from medical billing, from going to see their primary care doctor or anybody in the outpatient world. It's from paying $10,000 for $10 pneumonias. It's from having a culture where we wait and we react. And that's why we have half of all medical care, at least prior to COVID, being delivered in the emergency room systems. So the hospitals have zero incentive. In fact, in the emergency room, if you have a hemodynamically stable patient treated for whatever in the emergency room setting, they're fast-tracked. And hospitals are trying to figure out how to have independent emergency rooms, not even attached to a physical hospital. In Florida, I don't know in the Northwest if you have this, but down in this part in Florida, we have standalone emergency rooms popping up all over the place. I went to a standalone emergency room. My bill was $10,000 for pneumonia. I had pneumonia 2 years ago. And the same treatment in any of our centers, this is Stephen, it's less than $10. If you think about the cost of a chest x-ray, EKG, azithromycin, normal saline, it's just electrolytes. A bag of normal saline is like $1. I had 2 antibiotics. Rocephin's about $1. Azithromycin, 40, 50 cents. I mean, this is real stuff here. It doesn't need to be this way. And actually, when you look at just influenza at the hospital, when we have a bad flu season, who suffers in a bad flu season? The patients, obviously, and doctors too, especially primary care doctors. I mean, we suffer when our patients suffer. I feel it. But the hospitals, they celebrate a bad flu season. Hospitals are full. And I think that this is why all these hybrid models, as we're connecting with doctors, we have obviously the fee-for-service world. You got the full risk value-based care world. That's the world that we're in. But these hybrid models and even the ACOs, we're trying to reduce costs, but keep the hospital full. It doesn't work. In many ways, I feel like the hybrid models are worse than the fee-for-service. At least in fee-for-service, the average primary care doctor spends about 15 minutes documenting each patient encounter in the fee-for-service world. In many ways, these hybrid models are worse because not only do they have to document all that documentation in front of the patient, but in between visits, they've got to document as well. For God's sakes, we've got to move away from these failed systems.
So we've got some new models that can help us as we start to emerge from COVID-19. And we've talked about misinformation related to healthcare, related to COVID-19, but I think what all of us here can agree on is that we want to start making sure that we're putting out the right information about the models that actually can improve health. So those value-based care models like those at ChenMed, some virtual care models that give patients a better experience, better access to care. And the things that we've been talking about for a long time, but now it's been put into the public mind and it's made it very clear to even healthcare organizations that this is unsustainable. So I think with that, do we have any final points we'd like to make? And why don't we start with Dr. Lewis?
And so I would just say, specifically for the misinformation, look at your sources, look at the references when, a healthcare organization or the CDC posts information about something, they always provide the references. Go and look at those, find out, the population and as well as a lot of providers need to learn how to sift through that information. And then always, if you have a primary care doctor that you can go and speak to about this, definitely talk about the information that that you're receiving. And if you don't have one that will do that with you, then find one. That is what we will typically say at CHIDMED. So, I think the information, getting all of the news and information from social media it's a very powerful source. It is a wonderful thing to have. But with anything that powerful, it's really important to make sure that it's being utilized properly. I really hope that news agencies will at least end the paywalls for some of the pandemic information, so that people of lower income, people that don't subscribe, will be able to at least get that type of information. I think that that's something to look at for future pandemics, because a lot of that written information is reviewed and multiple people have evaluated the source, because it's important to have the right information. But our system should be built on really strong primary care, and we should let the emergency department take care of the emergencies, and let the specialists take care of their particular specialties when they need to, so that they can really focus on their job and not handle all the weight that the primary care physicians are capable of managing. But the only way to do that is to support the primary care structure, and that is not the way the system is built. And that's hopefully the direction that we go in one day. And I think we're learning a lot of lessons about that with COVID.
Great. Dave?
Yeah, I mean, I think that the thing that is easy to miss is some really great stuff going on at the local grassroots level. I mean, you think about great societal challenges, they always start to get solved at the grassroots level. And I think people have come to realize that the cavalry is not coming from, no offense, Robert, but the cavalry is not coming from DC to fix healthcare. We've had both parties in full control, and I don't think anybody thinks it's solved. And one of the key things that we're seeing is primary care is getting rebuilt locale by locale. You go to a place like Tyler, Texas, increasingly Denver, Seattle, you can actually get ChenMed type of healthcare throughout those metro areas. And one of the other things that has happened with COVID is every public entity, whether it's a city or a school district, budgeted for certain tax revenues, they've largely fallen off a cliff. And so they're now in a position where we got to do something. And that's one of the things that we're excited to see is, we just, in fact, work with a city in the Southeast that had a $7 million deficit. I think they were spending $22 million on healthcare for all their employees, and just getting healthcare right close that deficit. So the irony is, the best way to slash healthcare cost is to improve health plans and improve health benefits. I know you all have experienced that. It sounds like a paradox, but that's actually what happens. And I've even experienced it with my own family, with my dad's journey through Parkinson's, and how that probably saved, being in one of these great models, probably saved the taxpayers between $250,000 $1 million. He didn't spend one day in the hospital through that journey because he had the right kind of care.
Mm-hmm. Excellent. And Faisal.
Wow, great discussion. Thank you so much. We covered the medicine. We covered some of the cost of misinformation, just the financial dollars as well. Dr. Dan, how are you doing? Let's welcome Dr. Dan back. Thank you, Dr. Dan, for managing the chat and the comments. I appreciate that.
Absolutely. Great conversation, and misinformation is always rampant. So I think I appreciated you all tackling that important topic today.
And I feel like this is something that we'll be talking about more and more. I mean, we're seeing now, people are feeling it. When you're having the #1 cause of bankruptcy in the country by far being medical debt, and people start asking questions like, where's this coming from? I think that, and those of us who have the ability to influence, we should influence about increasing awareness. We should be talking more about investing in primary care. Yeah, these are the conversations that need to be happening. You don't need to be a doctor to know that this is the right way and this is what makes sense. So to our guests who joined us, both Dave and Stephen, thank you so much for joining today. This is great that you came. Dave, you have your book, and today you can download your book for free from Amazon.
That's right. Yeah, it's called Relocalizing Health. So you can go straight to Amazon, or you can go to the link that's on the screen, and there's a link off to Amazon. So just make sure you hit the click $0 to buy. It's kind of small text because they want to get you into the Kindle Unlimited. So hit the purchase for $0 and you'll actually get it for free. And even if you're not going to read it for a while, you'll have access to it.
Wonderful. Thank you all for joining us today. For more information about what we talked about, as well as the full risk value-based care model in general, please visit chenmed.com/resources. I believe that healthcare, access to healthcare, is a right, not a privilege.